Hi everyone, and welcome to your next installment in the McMaster Clinical Skills Radiology series. This is Evan Wilson again, at the time of making this video, one of the third-year radiology residents at McMaster. And I've been developing this series along with Nicole Lee, one of my co-residents, as well as Dr. Walker, one of the staff radiologists at the Hamilton General Hospital. So today we'll talk about the abdominal radiograph, specifically obstructions and pneumoperitoneum. And hopefully before watching this video, you had a chance to look at the videos on abdominal radiograph anatomy, as well as the different views that we acquire in an abdominal radiograph. And that will help you understand some of the principles and orient yourself as we go through this talk. So an outline on today's video, we'll talk about obstruction, some of the causes, what the findings are on an abdominal radiograph, and how to differentiate between small versus large bowel obstruction. And then we'll talk about pneumoperitoneum. Again, some of the causes of pneumoperitoneum, and then some of the findings that we see on abdominal radiograph. These aren't the only things that we look for on an abdominal radiograph. There's a variety of other findings and things that we can see on these studies, but these tend to be the reason why an abdominal radiograph gets ordered, to rule out obstruction or to rule out pneumoperitoneum. And in the spirit of keeping these videos hopefully nice and short and high yield, that's what we're going to focus on today. So what is a bowel obstruction? Well, really it's just a mechanical blockage preventing material from passing through the bowel, and that can occur at the level of the small bowel or at the level of the large bowel. So what are the most common causes of a small bowel obstruction? That's usually summarized nicely in this mnemonic ABC, which stands for adhesions, bulges, and cancer. So adhesions are usually kind of fibrotic or scarred bands that develop typically in the setting of a prior abdominal surgery, but they can also develop after non-surgical intra-abdominal inflammation, and they can even be congenital in some cases as well. And then bulges just stands for hernias. We just call it bulges for the purpose of the mnemonic to make it nice and easy to remember. And what that is a defect in the abdominal wall with some intraperitoneal contents herniating through. And then if that is going to cause an obstruction, it typically occurs at the neck of the hernia, where that defect in the abdominal wall kind of pinches down on the bowel that traverses through the hernia, and that causes a mechanical obstruction at that level. And that can occur as the bowel enters the hernia sac or exits the abdomen, as the bowel comes back into the abdomen at the neck of the hernia sac, or it can happen at both of those points, causing kind of a closed loop obstruction within the hernia sac. What causes large bowel obstruction? The most common causes are cancer, diverticulitis, and volvulus. So that's a little bit different from the etiology of small bowel obstruction. So once you have someone coming in and you verify in imaging that they have a small bowel obstruction or a large bowel obstruction, you'll already be starting to think a little bit differently in terms of the clinical implications or underlying cause of their problem. So the most common cause of a large bowel obstruction is cancer, which is definitely not the case in a small bowel obstruction. And then there's also this kind of more special entity in large bowel obstructions called a volvulus. And if you don't know what that is, it's when the large bowel kind of twists on its own mesentery, and that twisting actually constricts off the bowel at two different points, causing sort of a special case of a closed loop obstruction. And we'll get into a little bit more of what a volvulus is in the later slides. So when we look at the bowel in an abdominal x-ray, we really want to decide, is this bowel obstructed or is it not? And there are a few different features that we can use to help us decide this. Firstly, we want to decide, is this bowel dilated? Because dilation is really one of the key distinguishing features that occurs in a bowel obstruction. So how do we decide if the bowel is dilated on an x-ray? Well, there's this useful rule of thumb called the 3-6-9 rule. And what that stands for is just the level of, or the measurement at different levels of bowel that really act as the threshold for dilation of that specific area of bowel. So in the small bowel, we use a cutoff of 3 centimeters. So any small bowel on radiograph measuring over 3 centimeters in diameter from wall to wall is considered to be dilated. In the large bowel, that is up to 6 centimeters, so it can actually be normal for large bowel to be a little bit larger in caliber than the small bowel. So we don't start calling it dilated until it measures at least 6 centimeters from wall to wall. That's even greater measurement for the cecum, so that can actually measure up to 9 centimeters normally. The next thing we would look for is air fluid levels. So if there are multiple scattered air fluid levels, particularly if they're at different levels, that can give us an indication that there might be some degree of obstruction going on. It's not a super specific sign. It can be seen in ileus as well, but it is a useful supported finding. And really the clinical history becomes very important in a radiograph interpretation as well. So is this patient passing stool, or do they have a good history for ileus, like a recent surgery or recent intra-abdominal inflammation like pancreatitis, for example, which could cause their bowels to be sluggish and dilated in the absence of mechanical obstruction? Or do they not have a history that would suggest ileus, they're not passing stool, in which case we would be concerned for a mechanical obstruction if we do have the findings of dilation or air fluid levels on the x-ray. So we'll go into the findings of a small bowel obstruction first. Really, when you think about obstruction, you're looking for dilation upstream to the obstruction in the bowel. So really, it's just useful to think about it mechanically and where you'll see dilation if you imagine where the site of obstruction is. So of course, if you have an obstruction in the small bowel, you'll have dilated loops of small bowel upstream to that, and your large bowel should be non-dilated because you don't have an obstruction at that level. You may be able to see a transition point between dilated small bowel loops and non-dilated or collapsed, decompressed small bowel loops. Although when we're looking at a radiograph, it can definitely be very hard to point out any clear transition points, which is why if we're worried about an obstruction, all these patients go on to get CT, because with a better spatial resolution of CT, it's much easier to find the actual transition point or where exactly that obstruction is occurring, which can be useful in verifying the diagnosis as well as surgical planning. So the surgeons can see exactly where that obstruction is that they want to relieve when they go in surgically. We can also see air fluid levels, and the threshold that we have for calling positive air fluid levels is greater than 3. So it's normal to have up to 3 different air fluid levels. And we also want to look for pneumoperitoneum, and we'll talk about the findings of pneumoperitoneum a little bit later. So if you look at this radiograph on the right side of the screen, you can see in the mid-abdomen and left upper quadrant, there are multiple dilated loops of small bowel. These definitely would measure greater than 3 centimeters if you were to measure them. And there's also multiple air fluid levels, so one here, another one here, and more here as well. And we talked in the previous video how to identify air fluid levels. Remember that we also talked in that video that it's important that you're looking at a view that's orthogonal to gravity when you're looking for air fluid levels, because you really need to catch that interface between the fluid and the air. And if you're in the same plane as gravity, you won't have that interface developed. Also in this radiograph, you'll notice that the large bowel, which is kind of at least here in the right abdomen, full of stool and looks very normal in caliber. And we're not really seeing much large bowel in the left abdomen, maybe a few little scattered areas of gas here, but nothing certainly looks like dilated large bowel on this radiograph. So this overall would be very concerning for a small bowel obstruction. This is just another supine view in the same patient. So the last view that we looked at was clearly an erect view because we could see all those air fluid levels. And this is a good example of how now we're looking at a supine view. We're not orthogonal to gravity anymore, and now we're not seeing any of those air fluid levels. They've all disappeared because we're not getting that interface between the fluid and the gas in the bowel loops anymore. Again, we're really seeing some of the same findings, so just many dilated small bowel loops throughout the mid-abdomen and a normal caliber colon tracking at the right abdomen here and probably in the left abdomen and pelvis here. The bladder is bright on this radiograph just because the patient probably had a recent contrast administration and now the contrast is within the bladder. Here's another example in a different patient. So we have, again, multiple dilated small bowel loops in the left upper quadrant, which definitely would measure over 3 centimeters. And then there's multiple air fluid levels as well, both here, here, and here. Really, we're only seeing 3 air fluid levels in this case, which can be within normal, but that in combination with having them within these dilated loops is in itself concerning. And then we also see normal caliber colon, both in the right abdomen here, containing stool, probably some transverse colon crossing the upper abdomen here, and then also normal caliber stool-filled descending colon in the left hemiabdomen here. We can tell this is small bowel as well because, as we discussed in the previous anatomy talk, you can see these valvulae coniventes, or the folds of bowel, crossing the full diameter of the bowel loop, which is a good indicator that this is small bowel, because in large bowel, again, we'll see those haustra, which don't cross the full diameter of the bowel. This is a supine view in the same patient. So again, we're not orthogonal to gravity anymore. We don't see any more air fluid levels because we're not catching that interface. But we do again see multiple dilated small bowel loops in the mid-abdomen with valvulae coniventes. And we see normal stool-filled colon in the right hemiabdomen here, probably in the left here, although it's very difficult to see due to technical considerations. Another interesting finding that we can see on this x-ray is these valvulae coniventes, or mucosal folds in the small bowel, do appear quite thickened. When we see this in the large bowel, we call it thumbprinting sign, which is a sign of inflammation. So it may be useful to think of inflammatory causes, potentially, of a small bowel obstruction in this patient. So moving on to large bowel obstruction, really it's similar findings to a small bowel obstruction, but involving the large bowel. So if you think again mechanically of where the obstruction is, we need to see dilated large bowel loops in order to call a large bowel obstruction. Because if the obstruction is at the level of the large bowel, we want to see the bowel dilation proximal or upstream to that level of obstruction. So again, the features that we can use to look for the large bowel are haustra, those mucosal folds that don't extend across the full diameter of the lumen, and that picture frame orientation along the perimeter of the abdomen in terms of anatomically where the large bowel is located. We may or may not see dilated small bowel loops in the setting of a large bowel obstruction, and that really depends on the competency of the IC valve. So if the ileocecal valve is allowing for backflow from the large bowel into the small bowel in the setting of the obstruction, then that pressure that's developing from the obstruction can be released back into the small bowel upstream, and you'll see large bowel and small bowel dilation. And that's the typical case of a large bowel obstruction. In some cases, the ileocecal valve is what we call competent, which means we're not allowing backflow from the large bowel into the small bowel. That valve just mechanically won't let that pressure or contents back up. It's acting as a one-way valve. And that's the less common scenario, but actually the more emergent scenario in a large bowel obstruction. Because as you can imagine, if that pressure can't be released backwards up proximally into the small bowel, you're really getting a rapid buildup of pressure just in the large bowel, which is certainly less space or less bowel loops to allow for that pressure to build up before you start getting ischemia and perforation and those really things that lead to morbidity and mortality to a higher degree in the setting of obstruction. Again, we may or may not see a transition point. Again, it's very difficult to see the transition point on radiographs, although this is a good case of being able to see the transition point. And again, we might see air fluid levels, which could be in the large bowel, but also could be in the small bowel as well, if there's a backflow being allowed through the IC valve. So in this case, which is a great case, or a really good example, you can see markedly dilated large bowel here in the descending colon, and also extends into the transverse colon and into the ascending colon as well. And then this would be a case of an incompetent ileocecal valve because we're seeing, again, in the central abdomen, multiple dilated small bowel loops as well. We can see the haustra, which if the anatomy didn't already give it away, will be more supportive that this is large bowel that's dilated. So these folds that don't cross the entire lumen of the large bowel, and again on this side. And in this particular case, we can see this dilation really tapering down here to a transition point, and then we're not seeing any dilated bowel in the left lower quadrant distal to that. So we can be quite confident based on this x-ray that there's a large bowel obstruction somewhere in the left lower quadrant here. We can't tell what the etiology is based on an x-ray, but we know where we're looking when we do the CT for this patient because we're expecting to find the obstruction somewhere in here, regardless of what the cause is. This is another example of a large bowel obstruction, and it's kind of a special case because this is an example of a volvulus. So what you see in volvulus is you have twisting of the mesentery or the bowel around its mesentery, causing really in effect a closed loop bowel obstruction around the point of twisting. So you'll see this massively dilated bowel. It's really hard to tell because it's so dilated whether it's large bowel or small bowel really based on the features. But typically in volvulus, you'll see this massive dilation, more so than you would see this degree of dilation in other causes of mechanical bowel obstruction. And also you classically see this kind of loop of dilated bowel, which will project into one side of the abdomen, in this case the right side, and then kind of loop back on itself back toward the pelvis. And that makes up what's called the coffee bean sign. So this whole thing kind of looks like a big coffee bean sitting in the abdomen. And that's really characteristic of volvulus. You can get cecal volvulus and you can get sigmoid volvulus. The sigmoid volvulus is a little bit more common. And you can actually get a volvulus of the other portions of the large bowel as well, but that's even less common than the sigmoid and cecal volvulus. It's really tough sometimes to differentiate between a cecal and sigmoid volvulus on radiograph. They do say that if this coffee bean or bowel loop is projecting, like in this case up into the right upper quadrant, then it's more likely to be a sigmoid volvulus, where if it's going the opposite way into the left upper quadrant, it's more likely to be a cecal volvulus, but I don't think that's really the most reliable feature because both of them can do either one. So really you need to get a CT of these patients just to definitively tell what it is. If you do see normal sigmoid or normal cecum definitively, that can also help, but it can be difficult to tell in certain cases. This is a CT of the same patient on the left side of the screen, and this is just showing this is the level of the mesenteric twisting, and then this is the markedly dilated bowel tapering abruptly down to a transition point here at the level of obstruction. And if you were to scroll through this CT, you would see the other transition point as well, because like we said, this is going to have multiple transition points because it's one loop of bowel that has twisted and caused two transition points. This is a cartoon diagram just to help understand the anatomy of what's going on in a volvulus. So this would be your normal orientation. So you have a loop of sigmoid here, and this would twist on itself, causing obstruction at both of these points. You can imagine if you twisted this loop, it would constrict on both of these points of the large bowel. So you get this, in effect, closed loop obstruction where this is twisted, and you have two adjacent transition points with no way for the pressure building up within this loop to be relieved, and this now becomes massively dilated, giving us your coffee bean sign. And this is just an example of a coffee bean superimposed on that so you can see better what we're referring to with the coffee bean sign. So how do you tell if the bowel is obstructed versus if there's an ileus? Like we said earlier, clinical history is going to play a large part in that. But there are a few radiographic features that we can try to help differentiate. So in an obstruction, you'll see dilated bowel proximal to the level of obstruction with distal collapse. So if you can see, there's a lot of dilated small bowel loops, but you're having no dilated large bowel loops, and you suspect that the small bowel loops distally are also collapsed, then you can be worried that there's an obstruction as opposed to an ileus. If there are air fluid levels at different heights on an upright radiograph, such as in this case, you have air fluid levels here and then some at different heights up here, that's an indicator that there is some sort of pressure differential, which is more often seen in a mechanical obstruction than it is in an ileus. An ileus tends to have air fluid levels at the same level, and an ileus really tends to have diffusely dilated bowel. So if you see just dilated bowel loops everywhere, they involve the large bowel as well as the small bowel. It extends all the way to the level of the rectum, and you can see that on radiograph. And they have a good clinical history for ileus. That certainly will help you diagnose an ileus as opposed to a mechanical obstruction. So moving on to pneumoperitoneum, what are the causes of pneumoperitoneum? Well, it can be very sinister or it can be just an expected finding. So the sinister cause of pneumoperitoneum is when we have a perforated viscus, and that's seen in a variety of different clinical scenarios, the most common being peptic ulcer disease, like a perforated duodenal or peptic ulcer, a perforated small bowel obstruction. The pressure has built up so much that the bowel has now become ischemic, necrotic, and developed a perforation and now has gas leaking into the abdomen. An ischemic bowel, for the same reasons, developing a perforation. Diverticulitis, where the inflammation has become so bad that the bowel is perforated. And colon cancer, where cancer has just eroded through the bowel wall and caused a perforation. Settings where we see expected pneumoperitoneum are in recent surgery. So they've recently went into the abdomen and just air has been introduced from the external environment. Whether that's just a laparotomy through the incision itself or laparoscopic procedure where they actually injected air into the peritoneal cavity. And recent paracentesis, or really any procedure where they've violated the peritoneum and potentially introducing some air. So what does a pneumoperitoneum look like on a radiograph? Well, like we said on other videos, the most sensitive projection to pick up pneumoperitoneum will be your upright chest radiograph. And again, it goes back to basic principles, and I keep belaboring this point where you want to be orthogonal to gravity in order to see an interface between layering structures of different densities. So in this case, we're looking for air versus soft tissue or fluid within the abdomen, and we want to catch that interface. So air will float antidependently against gravity, and fluid and soft tissues will be located dependently with gravity. So if we do an upright chest radiograph, we'll want to look inferior to the diaphragm at the most antidependent portion of the peritoneal cavity to look for the air. So in this case, we have an upright chest radiograph. If you look at the superior surface of the liver, you can see it here. Just above that, you can see some extra lucency before you see the diaphragm crossing across the right hemiabdomen. So this is an example of pneumoperitoneum above the liver and below the diaphragm. You can again see some on this side as well, underneath the left hemidiaphragm. So this is pneumoperitoneum, a very thin hemidiaphragm. And then it's just important to note that the stomach bubble will be located in this area as well. So you don't want to confuse the stomach bubble for pneumoperitoneum. In this case, you can see the air fluid level within the stomach, a nice stomach wall, and then some air outside the stomach underneath the hemidiaphragm. Just another case, or a few other cases in multiple different patients. So again, we have the same principle, air above the dome of the liver and the right hemiabdomen, and a nice thin diaphragm which projects over that, giving us a diagnosis of pneumoperitoneum. And that air can cross across both sides of the diaphragm. So again, we're seeing it above the liver here, the diaphragm here, and again, pneumoperitoneum above the stomach with the stomach bubble here, the wall of the stomach, and then the pneumoperitoneum and the diaphragm. We don't have to have an upright chest radiograph. It is the most sensitive, but any plane that's orthogonal to gravity will have a good sensitivity for picking up pneumoperitoneum. So the other one that's most common is the left lateral decubitus. So the patient's laying on their left side, and the air will float antidependently over the surface of the liver and against the abdominal wall. So here you can see this large amount of pneumoperitoneum settling above the liver, and then this air fluid level. So this patient also has free fluid in their abdomen as well. And this would be an infant patient if you're wondering why the skeleton looks so different. So is this pneumoperitoneum? And I included this just to make another point where not everything that's lucency under the diaphragm is always pneumoperitoneum. It's important to look closely and see Is this a bowel loop? Do you think this is the stomach bubble, etc.? So in this case, we can see clear haustra, these folds within the bowel. We can even see a little bit of a contour change as these folds press against the diaphragm. So really this is just a loop of large bowel interposed between the liver and the diaphragm with gas within the bowel loop. So there's no evidence of pneumoperitoneum on this image. It's important to keep in mind that there are other sources of extraluminal gas that you can see on a abdominal radiograph. That being pneumatosis, which is gas in the bowel wall, and that looks like kind of bubbly lucencies tracking along the wall of the bowel. That's often associated with bowel ischemia, so it certainly is a concerning finding. We can see portal venous gas, which is branching lucencies within the liver, particularly seen in the periphery of the liver, also associated with bowel ischemia. And we can see pneumobilia, which is gas in the bile ducts, again, branching gas projecting over the liver, but it's typically more centrally located near the liver hilum. And that's typically seen after surgical procedure to open up the sphincter of Oddi, a sphincterotomy, or potentially if the patient has had some other sort of biliary drain inserted. In the spirit of trying to keep these lectures as short as possible and reasonable to watch for your clinical skills sessions, I didn't include kind of detailed images and labels and going over what these look like, but I just wanted to let you know that these are findings that we need to look for, and I want to call your attention to that. That's the end of today's video. In summary, we went over bowel obstruction, both small bowel and large bowel, what the causes are, what the radiographic findings are, and how we can distinguish between them. And we talked about pneumoperitoneum, some of its causes, both sinister and expected, and what the findings are on abdominal radiograph. Thanks for listening, and please tune in to the next video.